I was fortunate enough to be part of a pre-meet about a week ago when we were organising the layout for this webinar today, and I was privileged to hear a very enthusiastic presentation by Ray Dalton on some of the work that he's been doing. So I'm absolutely delighted to welcome Ray now to give us a snapshot of some of the fantastic work that he and his team have been up to. Ray.
Well, thank you very much, Daniel. And thank you for all the people that have dialed in and logged in here. Great presentation by Tazeen and Roberto, and really everyone's right. And that's the great thing about this meeting is it's the pieces of the puzzle that actually make the healthcare system work. And the Dalton Foundation and Relink Global Health, we actually think about it holistically, and we think about how do you effectively deliver a healthcare delivery system where that healthcare can be delivered from a community basis. And part of that is actually connecting and collaborating. So in 1999, my wife and I started the Dalton Foundation. Next slide, please. And what we thought about was how do you know where to help if you don't know where help is located currently? If you don't understand where the healthcare deserts are located, and you only know where the tropical forests are, we tend to put our energy into the wrong places, but all in good nature and well thought out. So we've actually developed a 3-process approach to implementing healthcare systems in second and third world nations. We're working in Haiti now, we're working in Malawi, we've also worked in Togo, Africa, parts of India. And what we do is the first thing we did is we built a cloud-based technology solution called RelinkGlobalHealth.org. And what Relink Global Health does, it actually is a geolocation system that identifies the current healthcare delivery system. So the first thing we do is we meet with the Ministry of Health and we talk about what we're looking to accomplish. We're not looking for money. We're looking for whatever information they have about what is currently available. And our database includes government, non-government, faith-based, and private pay. So imagine if a missionary physician shows up at a medical clinic in a city, and he's an orthopedic surgeon, and somebody with a diabetes wound shows up, where do they send them? How do they know where the marketplace is at? So we have both a printed directory as well as a cloud-based solution that currently lists all of the healthcare locations, the number of doctors, the number of caregivers, the type of devices that are available. So next slide, please. And what we do is we think about how can that market be delivered in such a way that it is a community-based, it's as close as possible to the person needing the service. And what happens there is by knowing where the equipment is and knowing the hours of operation, we can also now begin to assess, is it equipment that is causing healthcare not to be delivered, or is it actually another area? And what we found out in Haiti as an example, we found out that 64% of the caregivers, doctors, nurses, community health workers, did not even have the very basic tools to deliver healthcare. They didn't have a stethoscope. They didn't have pulse oximetry units. And so instead of figuring out what equipment to give them, we figured out how to equip them first. So in 2020, we actually began to equip the caregiver, to give them the tools they needed to be able to do the work. And just that small amount of equipping 225, we're now up to over 550 kits, they have seen over 600,000 more patients in 1 year, 600,000, just by finding out that the real problem was lack of tools, diagnostic tools. They had the education, they had the ability, they didn't have the tools. Can you imagine if you can divert 600,000 people away from showing up at a hospital in a low or no income basis and clogging up that system? All of a sudden we freed that hospital up to actually treat people who needed a higher level of care. Then we move, if you go to the next slide, please, then we move from really knowing where they're located to knowing what they need to really now thinking about what equipment is actually required and where is that equipment required to treat those people that need hospital care. So we found this out by error. We found it, we had a request for an ultrasound unit in a particular village, and we asked all the right questions. We asked, what equipment, how's it going to be used, who's going to service it, how's it going to, training going to be going on, and we sent this ultrasound machine. Then 2 weeks later, we get a request for another ultrasound machine, and it's literally like 3 blocks away. And so we asked them, did you realize that there's an ultrasound machine that just got delivered about 3 blocks away? And they said they didn't even know there was a clinic 3 blocks away. And so by building, if you're going to build a healthcare delivery system, you have to link these puzzle pieces together for an effective system. So if you look at what Tazeen has done, if you look at what Roberto has done, they now know where everything is at. But in our case, we've actually made this a cloud-based technology so that everybody can see it. So it's actually available. So even though it's a private pay, that may be the best option because it's 1 kilometer away versus 100 kilometers away. So then we began to boil down or distill down this data. And we said, okay, how do we now modernize and standardize? So in order to build a part solution or service solution around medical devices, the first thing you have to do is you have to figure out who's going to work on them and how are you going to get them the training and how are you going to support these individuals. And we found it just almost impossible, even in a small country like Haiti, to have, there's literally over 28,000 different makes and models of devices just in Haiti. It's impossible to believe that we could provide an efficient education system, efficient support system on that diverse makeup of medical devices. So we began to look at really what happens here. What really begins to happen is let's focus on where people enter the hospital. They enter through the emergency room, they enter through surgery, they enter through the NICU. And what are the critical devices that could be standardized by make and model? Because by standardizing, we then can effectively put a training and a manual in place in the country. So we ask each of our participating hospitals to give us a biomedical designee. I mean, we all know that honestly, that's not a biomedical technician, it's not a clinical engineer in many cases, but it's someone that is a designee that can do that first call. Because in the US, 58% of the calls that we would respond to when I owned and operated service companies were no fault found and could not duplicate. So what we really want to do is we want to take out that gap of responding to things and just turn it on, turn it back off, check your switches. So we built this first call capability at our partner hospitals. Now, the unusual thing that we're doing is we actually have started an independent service organization in the country of Haiti that will respond to calls with in-country parts and in-country loaners on items that we have standardized. So if we're going to put equipment in, it has to have 5 years useful life, it has to have parts access for 5 years, and it has to have acceptable training. So what we're looking to do in the 23 hospitals and 138 clinics that we've been working in so far, and it's expanding nationwide in Haiti, is to build a first call capability at the hospital by standardizing critical care equipment and expanding that platform as we go out, to have somebody there that can connect to a in-country service capability. And this may sound strange to you, but our first level of interaction is to respond physically within 7 days. Now, people say 7 days. Well, today it's 7 months, right? So to go from 7 months to 7 days is really changing logarithmically. Now, we want to get that down to even less. And to be able to actually show up with a part and for the machines that we know have been installed is critical. We back that up today with a network of US-based tele-support people by specialty. So when that first call guy talks to the guy in country, that guy in the country then can connect to a specialist in the US. So when we arrive for that call, we can actually have the part available and we can actually make the repair. So in closing, go to the next slide, please. In closing, we really think about building a healthcare delivery system holistically. It starts with knowing who's participating in the market, knowing the hours and the capabilities of those places, knowing what equipment they have, then solving the problem. So we don't rush to the problem. We rush to the data around the problem, and then we systematically think about how can we solve this problem. This tool is cloud-based. It's relayinglobalhealth.org. It could work in any country. So there was a question earlier. Somebody said, well, how do we start? Well, first thing you have to do is you can get a hold of us and we can open up the administrative window for you to log your country, where you can begin to log the locations, you can log the caregivers, you can log the specialties, you can log the devices. Because once you know where things are, you have a much greater likelihood of being successful on improving and supporting them, but you have to know where the devices are first. What COVID proved to us in Haiti and Malawi and other countries we're working in, it's the problem was still there. It just accelerated the need to solve it more quickly and more focused. So instead of taking a global approach about, hey, what do we have in the building? It's what are these 7 or 8 devices? What is the status of those? And they must work now. They became hyper-focused on respiratory working and anesthesia working and pulse oximetry working. And so it gave us the opportunity to really say, if we're going to bring more equipment in, the junk has to come out. And that's one of the conditions of being a partner. Today in Haiti, we have over 2,000 partners in the Haiti Health Network, which is unbelievable. And over 600 of them have participated both in service-related education and in partnering with us on modernization. And thank you very much. But again, it's just one way of approaching a problem around clinical engineering and service management. And thank you for your time.
Great, thank you very much indeed. Didn't I tell you, everyone, that we would get an enthusiastic presentation from Ray? So that was fantastic.